Can everyone see my slides?
Yes.
Great, thank you. So just some disclosures, I do serve as a grant reviewer for the Nielsen Foundation, and I receive partial grant support from the NIH, the DoD, and several foundations. Today, I'm hoping that by the end of my presentation, we'll be able to describe 3 core domains of quality measurement as they relate to spinal cord injury care. We'll be talking about the Donabedian model and looking at some structure, process, and outcome measures. Compare and contrast coordinated SDI care with 1 to 2 other complex medical care models. And specifically, I think it's relevant to look at transplant populations, diabetes management, as well as chronic kidney disease or dialysis populations when we look at chronic and complex care models of care. And then at the end, I'm hoping we'll be able to reflect on 2 to 3 challenges and opportunities facing spinal cord injury providers and systems. Some of these overlap, but I think they represent really important ways to build on the phenomenal work that historically has been done within spinal cord injury and is also still being done today. And like a sampling of these, I would say, includes things like value-based care models, looking at care continuity across settings, and then really measuring health equity and value, and how we can help promote health equity by better measurement of value. Okay. So when we talk about quality measurement, quality can seem like a really abstract concept. I know that there's phenomenal work being done at the Hopkins system with, I think, the Armstrong Institute, and folks at Hopkins have done really amazing quality work in PM&R. But to folks who are not as involved in quality every day, it can seem, like I said, a little bit abstract. And so when we think about this, we often reference back to this really touchstone report, the Crossing the Quality Chasm, done by the Institute of Medicine, now the National Academies, in 2001. And that demonstrated that we want to have care that is safe or avoid harm. We want care to be effective. So we want to avoid underuse and misuse, and provide services that are based on evidence, and refrain from providing services that really won't benefit anyone. We want to provide care that's patient-centered, that is respectful and responsive to individual patient preferences, needs, and values. And we want to have timely care by reducing waits and sometimes harmful delays. We want to provide efficient care and avoid waste of really a lot of things, but mainly equipment, supplies, ideas, and energy. So not just waste of material goods, but also waste of providers' time. And lastly, we want, but certainly not least, we want care that is equitable. So providing care that does not vary in quality because of personal characteristics like gender, race, ethnicity, geographic location, and socioeconomic status. And really, I think that's what we think of as aspirational quality care. When we talk about measuring quality, and also this, so quality of, when I looked at quality of care generally, as we can see, there's a lot of interest in this, but it dates back, a long time ago, but especially in more recent years, and I would say definitely within the past 2 decades since the IOM report, there's been sort of exponentially more interest in quality of care. When we talk about measuring quality of care, we tend to think of 3 different domains, and this is based on what's called the Donabedian model, and things that we measure when we look at the quality of care that a system provides or that a clinic provides. These are bigger things that are sort of outside of an individual provider's performance. But when we look at quality and we try to measure it across a system or across a clinic or across an institution, we look at the physical structure. So things like the actual physical building, are things accessible? The capacity of the building to take care of patients, and the staffing of that building, things like policies and procedures, information technology, leadership, the organizational culture, and something we talk a lot about at our rehab center is safety culture. So safety culture, just culture, and promoting safety culture among everyone who works there, especially frontline staff. And then not just the numbers of staffing, but also their expertise, their training, their certification, and any sort of staffing ratios. These are all thought to be part of the structure and how we can measure structural components of quality. Next, we think about process and things that are processes that are not clearly defined as structural characteristics, but are, and not clearly defined as outcomes, but are things that are thought to be related to the provision of high quality care. So a classic example, or several classic examples, would be things like hand washing. So hand washing is not necessarily an outcome of care, and it's not really part of the structure of an institution organization, although it does relate to things like culture and norms, but it is something that is associated with positive outcomes and thought to be associated with receiving high quality care. Another thing that gets measured that's a sort of a classic process measure is our things like employee vaccination and immunizations among healthcare workers, for instance, and measuring that. And the thought that by virtue of protecting, for instance, immunocompromised patients, is something that, again, is not an outcome nor really a structural metric, but is something that is thought to be associated with higher quality care. And in general, you can get sort of conceptual and technical and think about the process as being defined as the way that policies are translated into practice. For instance, technical processes that relate to how care is delivered, and interpersonal processes, or the manner in which care is delivered. And so this might be something related to, for instance, responsiveness to patient questions, timeliness of response to we can think of call bells, patient messages, like all these things that we could measure as being part of a process that are not necessarily an outcome of the care itself. And then we get to outcomes, which is usually I think the meatier things, and also more controversial things sort of live in this bucket, where really it can encompass any effects of healthcare on either patients or specific populations. So these can be changes to health status, changes to behaviors around health, changes to patient knowledge, patient experience, cost and reliability, and things like health-related quality of life. And so we have very big and blunt measures of outcomes. So things like mortality, surgical complications, and then we have things that are a little bit, I would argue, both more granular and sometimes harder to measure, but yet these things can be sometimes more meaningful. So when we think of, for instance, disability ratings, or we think of functional scoring, and also things like measures of community participation that we look at sometimes in, for instance, the spinal cord injury model systems, these are things that are outcomes. And then we'll look at a little bit later, one of the challenges and opportunities, but how are we measuring healthcare costs? And I think this is one of the most controversial outcomes, but that is where sort of that would live within this quality measurement spectrum. Okay. A fourth bucket would be balancing measures. So the National Health System in the UK often looks at this one as sort of the fourth bucket, and they sort of have the Donabedian plus model, but they look at balancing measures, and this is I think a good measure to think about, and one that serves us well when we're thinking about especially some of our complex rehab populations. But this asks essentially whether there is a measure of anything that we should be looking at that represents an unintended consequence, because if you there's a lot of sort of pithy sayings, but if you can't measure it, you can't pay attention to it very well. And so keeping in mind that as we're measuring all these things, and we have a lot of benchmarks, and we're very concentrating on these structure, process, and outcome measures that we've decided are important in any QI initiative, then we need to be looking at balancing measures too, as we're going along on any initiative or any improvement project, to make sure that we're not having unintended consequences that we would really rather avoid, even if everything else seems like it's looking rosy. So I thought, in terms of spinal cord injury and spinal cord injury models of care, structure, questions we could ask about structure would be things like, is the facility accessible for people with SCI or mobility impairment? Does the team have spinal cord injury specialists? Would be a question, or can they access spinal cord injury specialists? For process, we can think of, does the team provide care based on up-to-date clinical guidelines? I forgot to mention in process, but part of process would be also use of guidelines for care, something that's not necessarily structural, but not necessarily an outcome, but is associated with higher quality care. So adherence to guidelines or use of guidelines. And then our policies periodically reviewed to incorporate new evidence and findings would be a process measure as well. For outcomes, if I were a spinal cord injury patient and I were looking at, be it a primary care practice, be it a hospital, I would ask, whether spinal cord injury patients have outcomes that are comparable to other facilities with the same level or severity of injury. And then, are those with spinal cord injury able to return to community education or employment after their injury? This is a big one that tends to be looked at in registry-based studies within the UK, Europe, and then also in the spinal cord injury model systems. For balancing measures, like I said, we want to think about, are there any unintended consequences of existing quality initiatives for spinal cord injury patients? And I think this is important to think about when we're thinking specifically about spinal cord injury care models, but also things that are broad quality measures. So for instance, I know that some colleagues at the American Spinal Injury Association have been working on looking at ways to advocate for changes or modifications to some of the quality measures based on urinary tract management, and thinking about what does a catheter-associated urinary tract infection mean for a spinal cord injury patient who is in the acute period after their initial injury, versus what does it mean to a general geriatrics population? And so thinking about, if we incentivize people to completely eliminate catheter-associated UTIs, are there any adverse consequences, for instance, in terms of renal health or in terms of autonomic dysreflexia, if we're trying to totally avoid using catheters in the acute setting, versus maybe a more nuanced algorithm-based management strategy. So when we think about structure, I'm just going to go through some examples here, but first, spinal cord injury model systems and really models of care, not model systems. We think of structure, we can think of things like, for instance, the VA's hub and spoke model as being a structural component that we could measure to look at and assess quality in spinal cord injury models of care. We can think about spinal cord injury model systems, and in the UK, we can think about the spinal cord injury centers of care, which is something that is sort of similar but exists in the UK and also in Ireland. We can think of great institutions here in the US, like the Kennedy Krieger Institute. And so we can think of things that are available in those institutions and also as part of the programs within those institutions and their collaborations across clinical affiliates. We can also think about things like the Christopher and Dana Reeve Foundation and United Spinal, and resources that exist that are things that spinal cord injury models of care may draw on, that may be national resources, and that can be used by both patients and or consumers and clinicians as well. And then we can think on a more contextual level, things that are local, so not national resources, but maybe local community resources, like the availability of gyms, the availability of accessible fitness facilities, and the availability of adaptive sports programs. And again, on a very granular level, we can just think about, is something accessible? So, if I am referring somebody from our spinal cord injury clinic, for instance, for a mammogram, I have to know where the accessible facilities are, and I have to know the appropriate place to refer the patient. Otherwise, they may go and they may not actually be able to get the test. So thinking about how to organize care and what the structural resources are can help both with quality measurement for a system, and then also for me as a clinician to do my job and to help have the highest likelihood of the patient getting that preventive care. For process measures, we have a lot of process measures and really tools in our toolkit as spinal cord injury providers. We have process measures, for instance, within the spinal cord injury model systems, usually there's a lot of acute care systems that will use something like this, but whether somebody comes and performs an ASIA exam or performs a neurologic exam within a timely fashion initially after injury is something that would be a process measure of quality care in spinal cord models of care. The VA, just going back to the VA, that's I did my fellowship as part of the VA, but they have a whole directive that's sort of written into policy in terms of the systems of care and what those systems should be. And so this is not only touches upon structural issues, like they have a whole section on staffing for spinal cord injury units within the VA, but this also touches upon process measures. So things like annually, what would be optimal for somebody to get in terms of their urologic screening. So this is where we get, you should have an annual kidney ultrasound, and you should have an annual measurement of, both upper and lower tract function. So we need to get a UA and a creatinine and a BUN on you every year to make sure that we're monitoring your upper and lower tracts. And so this would be a process measure. We also have guidelines. So we have really a wonderful suite of guidelines that exists for spinal cord injury providers and for other providers that are public and free of use, that thanks to the Paralyzed Veterans of America. But these really run the gamut from resources on early management and early acute management of adults with spinal cord injury to things that are, related to longer term outcomes and functional prognostication. More recently, I wanted to share, there's a resource, the American College of Surgeons, who look at trauma systems of care and what resources are required for trauma systems of care that also, similar to the VA directive, touch upon these structural and process components, put out a best practice guideline for spine injury. And this also has some great information on it as well, that I think it probably has a little bit more of a surgical focus since it's put together by the surgeons, but thankfully also includes a section on rehab and really what aspirational trauma systems should have in terms of spinal cord injury rehab for folks who sustain spine injuries. For outcomes, there's a lot of outcomes we look at in spinal cord injury, but we do look at the ASIA score and sort of change in the ASIA score as an outcome, not just performance of the exam, but the injury severity and whether folks, for instance, return to walking and return to independent functional status. This is a wonderful review that came out a few years ago, but looked really at both data from the US, and then the various European databases in terms of looking at prognostic factors for walking after a spinal cord injury. We also have more granular levels of injury. This is a wonderful reference, again, from the PVA, but this actually will look at and sort of give you different estimates in terms of home care and, on the basis of level of injury, what your estimate would be for your basic ADL tasks and then your home care, and gives what I think is really wonderful about this guide is that it gives you a hypothetical target, and then based on the research, what the actual range was. So if somebody, for instance, needed 6 hours of care per day, that was sort of the projected, theoretical target, But in reality, maybe some people needed 4 or 5 hours of care a day, and some people actually needed 8. And so they'll give you actually the interquartile range by level of injury. And so this is really, I think, unique to spinal cord injury and models of care, in that we do focus on things that are very important for community reintegration and community participation. And we look at these in both a context specific and then sort of a global lens. Another outcome that I think is important to consider are things like secondary health conditions. So spinal cord injury is a catastrophic injury that happens initially, and then folks are living with it for hopefully a long time afterwards. But in that time, we manage a lot of different conditions. So my work as an outpatient spinal cord injury physiatrist, this is our bread and butter in terms of managing very prevalent secondary health conditions, and trying hopefully to avoid things like, for instance, recurrent urinary tract infections, pressure sores, and complications from autonomic dysreflexia. And we do have sort of a rich epidemiologic tradition within the spinal cord injury of looking at trends in mortality and trying to, I think, reduce excess mortality, and have made strides in that within the past several decades, but still struggle within sort of the first year after injury, dealing with some of the acute complications, since folks are at higher risk, for instance, of things like PE during that initial period. Okay. So I want to talk a little bit about complex and chronic care models of care. This really came to the fore in the early 2000s with Bodenheimer's article on improving primary care for patients with chronic illness. And this sort of took I think, sort of the public health field and some clinical practices by storm, in terms of thinking about how do we get away from what he called a tyranny of the urgent, to a really planning deliberate care for people who are living with chronic illness. So this article starts with a case presentation where Mr. Sugarman, who's a 64-year-old patient with diabetes, comes in for a 15-minute primary care visit, and essentially 12 minutes of it is used to deal with acute knee pain and some gastroesophageal reflux, and then there's 3 minutes, whole 3 minutes left to deal with diabetes, or this chronic condition that Mr. Sugarman is living with, that really gets short shrift here, and so this talks about sort of a way to re-envision that, and to think about visits that are dealing with acute conditions as being sort of their own set of visits, and then really a really rich multidisciplinary way of approaching chronic conditions like diabetes with other members of the team. So for instance, nursing, nutrition, podiatry, to avoid these end organ complications, and also having sort of specified scheduled visits that focus on longer term non-acute conditions, to help people live well, and really collaborating with the community to provide those. Okay. And this has morphed into several things. So this is a more recent schematic from UCSF in terms of thinking about the patient-centered medical home, which was had sort of many acolytes in the past few years, but really thinking of something that is more multidisciplinary, even co-located. So when we talk about integrated behavioral health care, we're thinking about actually integrating behavioral health psychiatrists, psychologists, behavioral health care social workers within a primary care practice, instead of the traditional, maybe a primary care provider acting as a gateway, and then referring out to a series of folks that may not actually be located together, or actually even really talking together synchronously, or sharing ideas about a patient. And the six components that Bodenheimer thought should belong to the the chronic care model were here, but essentially things like community resources. So are there, I apologize for some noise, but so things like community resources, and whether there are actually, for instance, fitness centers in the community, things like healthcare organizations. So does the healthcare organization, does the organization itself have priorities like community health and like getting people back into the community? Or is that just sort of an aside that is not a primary goal? Self-management support. So are there resources to help self-manage and to help patients or consumers learn new things or learn to manage their situation better? So for instance, one thing I think of is, are there wheelchair skills workshops that are available to community members, or are they sort of only offered in informal therapy sessions? Or, are there even therapy sessions that focus on that community reintegration piece versus things that are sort of more within the hospital itself and not focused as necessarily on that community integration piece. Clinical information systems. This may seem quaint now since we sort of all live and breathe and sleep in the EMR. But in 2002, this was I think thought to be sort of more provocative in terms of thinking about recording things electronically and being able to track them over time within an electronic medical record. Again, things that we, I think, largely take for granted, but I think we're still fine-tuning ways, for instance, to capture the ASIA exam in the electronic medical record. I think when I talk to folks from across the country, everybody is doing this a little bit differently. Some people have flow sheets, some people just have a text, some people are capturing it in a photo with a PDF. And so we still do these things, but I think our level of doing them is probably more advanced than it was in 2002, certainly. Delivery system, decision support. So again, are people using clinical practice guidelines? Are there guidelines available? Within SCI, certainly there are, but we can think of maybe other chronic conditions where they may not be as advanced. And then delivery system design, like I was talking about. What does the team look like taking care of the patient? Is it different for inpatient and outpatient environments? Probably so, but does that differ, for instance, across institutions? Yes. And are there consequences to those differences, or are there efficiencies that are offered within certain contexts? So we'll talk a little bit about models of care for both diabetes and chronic kidney disease. So for chronic kidney disease, Nickel and colleagues looked at over 2 decades of, I'm going to go get a headset. Hang on just 1 second. I'm going to mute myself and I will come right back. Can you guys hear me?
Yes.
Awesome. Thank you. All right. Sorry about that. So we're going to talk a little bit about models of care for chronic kidney disease and also diabetes management, which are 2 sort of very prevalent chronic diseases that we see a lot. And we see also these tend to be the focus of big payment models, for instance, for Centers for Medicare and Medicaid Services, because they are so prevalent. So Nickel and colleagues did a review where they looked at over 2 decades of publications on models of care for chronic kidney disease, and Del Valle and McDonald looked at sort of 1.5 decades worth of publications looking at chronic care management services and models for diabetes care. And they found for chronic kidney disease that there tended to be 4 main types of care models across the 2 decades of publications. And these included
nurse-led team models, multidisciplinary specialist teams, pharmacist-led models, and then essentially like self-management models where people were empowered and given a lot of education, but ultimately in charge of managing their own chronic kidney disease in terms of their medication management, and then also looking at outcomes. They actually found, and this was interesting and I think humbling as a physician, but they found that nurse-led and pharmacist-led teams actually did the best with prescribing drugs that were relevant to chronic kidney disease. I think maybe this can be attributed, I think as physicians, we tend to, I think, have a good appreciation for the exceptions. And so we may be sort of looking for the exceptions, and it may be the case that nurse-led and pharmacist teams are better at following the guidelines because they're stricter about the guidelines maybe. But they did find that there were a lot of heterogeneous studies, and there was frequent high risk of bias that was noted. This, I think, is understandable because it's hard to blind a care model, and it's hard to perform a randomized clinical trial on a care model with appropriate blinding. And so these studies are limited by the fact that there is a lot of bias that is part of the analysis. And in some ways, it's hard to get around that by designing the bias out of it. I think one thing I think that is a strength of ours in spinal cord injury, but we can see here is that there's evidence, there's limited evidence of long-term improvements for renal cardiovascular mortality endpoints in the studies of the chronic kidney disease models because there's only short-term follow-up. And so this is something that we, I think, struggle with in spinal cord injury sometimes, in that we do get a lot of information upfront in the acute care for patients, but our registries, both in the US and in the EU and the UK, I think are strengths because they do allow us to follow a smaller subset of values longer term. For instance, looking at 5-year or 10-year follow-up, even 15-year follow-up in the spinal cord injury model systems. I think especially colleagues at UAB have been looking at mortality for a long time and have used the registries to a good purpose with that. For chronic diabetes management, the chronic care model has been used across US primary care settings. I think there are differences of opinion on how valuable the findings are. There are findings that it has helped with some outcomes, but the scalability and for instance, the sustainability of those models is debated because at different time points, reimbursement strategies have not always aligned with creating or providing a chronic care model within, for instance, a smaller practice setting. The others, Del Valle and colleagues, note that there have been improvements in electronic medical record capabilities and in delivery system redesign that align with reimbursement policy, for instance, offering things like nutritional consults and podiatry to individuals with diabetes as part of their Medicare benefits. And then they did note that fewer strategies overall address things like community resources and the capture of process measures. And as we saw at the beginning, process measures are kind of like the middle child of quality measurement, where they get captured if they're part of a payment program, but they're not always what people are looking at as sort of the end product of care. And so sometimes things like a patient's attitude about something and measuring that may not always get captured. And so, something may have been very positive for patients, but if you're not capturing that positive change, then it's not necessarily be valued in the or looking at the sustainability of the initiative. And fewer strategies addressing community resources. This is something I think that we do better at within spinal cord injury. It may be because we have a smaller population with very focused needs. But this is something that gets there's a lot of talk about it, and you know, authors talk a big game about it when they're talking about chronic care models, but how it's actually done and how that gets operationalized for systems and providers and clinicians, I think still tends to be somewhat abstract. And so successful models of it, I think, get described, but then how to translate that successful model into another setting is sometimes a bit modest in terms of the explanation. Okay. Another important set of care models I think it's important to consider are transplants. So there is actually a fair amount of the transplant system within the US that is sort of mandated by statutory guidance. So what you have to have in place to have a certified transplant program and the types of things that you must have in a process that I think is even more formalized than some of the trauma systems of care that we saw from the American College of Surgeons, who you know, historically have opined about what is required and what should be required from transplant centers of care. And so this, I thought, was a great review looking at practical recommendations and care models, specifically looking at management of modifiable risks in both kidney and liver transplant recipients from the COMMIT group, or the Consensus on Managing Modifiable Risk in Transplantation group, which tend to be a group of physicians looking at transplant medicine. And as I said, a big thing that they look at is how to minimize the risks of the non-adherent transplant patient, right? So somebody has had a kidney or a liver transplant, and you would really like to avoid all of the sort of things like graft rejection, and you want to make sure that they're taking their medications and they're able to do that reliably, so that they are at less risk of having a graft rejection. What they've noted in terms of the cycle, they perform a lot of psychological screening pre-transplant, and they look at how to identify early on non-adherent transplant recipients, and they also look at multi-level risk factors for non-adherence, including things like sociodemographic factors, patient-related factors, treatment-related and condition-related factors. So for sociodemographic factors, we might think of somebody who is socially isolated and does not have as robust of a support system. Patient-related factors, so things might be related to comorbidity, so depression, low self-efficacy. Treatment-related and condition-related factors, so things like just the size of the pill, the fact that it may taste bad, the fact that it may have bad side effects, and may make them, for instance, more depressed. And then things like healthcare teams and systems factors. So do they have someone who is well-versed in community resources? Do they have systems factors could be things related even to issues with transportation and accessibility of the clinic. And they will look at strategies for managing non-adherence within some of these care models. And what I found fascinating about this was they remarked that education on the value of adherence to immunosuppressive medications for transplant populations is important, but the effect of providing more education is actually very modest in terms of how effective it is at getting people to be adherent. It's generally thought not to be the most effective modality actually to help promote adherence. The educational cognitive interventions and things that are medical interventions tend to actually be more effective. So these can be things like, trying to explore, why somebody may be averse, trying to provide a psychological intervention, trying to improve their self-efficacy, and even things like trying to figure out whether, is Is it because they're too busy during the day? Are they a caregiver? Could they be more effective if we change their medication regimen to something that they only needed to take, once a day versus multiple times a day? And so really thinking about that in terms of the patient specific context and the community context of the patient. Okay. So I'll talk a little bit about components of coordinated spinal cord injury care next, and hopefully we'll be able to compare them to some of the other complex care models that I just mentioned. When we think of coordinated SCI care, hopefully we're thinking about coordinated specialty and primary care that is aiming to deliver evidence-based care to patients with a holistic perspective on health that prioritizes long-term function and community participation. We think of patient-initiated visits to address acute issues such as spasticity and pain symptoms and equipment issues, and then also scheduled visits that focus on anticipated issues such as bone health, immunizations, and things like diet and also aging. So again, I think like I told you, the VA wrote a whole book on sort of spinal cord injury systems of care, and this, I think, if you've worked in the VA, this is very reflective of how the VA deals with care in terms of there's an annual visit, there's sort of an annual clinic visit that's quite comprehensive. But when we think of other models of care, even in primary care, sort of an annual wellness visit, we can see the parallels here in terms of thinking about a patient-initiated visit for a new problem or a new issue that has come up, and then things that are scheduled that really focus on things like anticipatory guidance and longer-term concerns. We think of coordinated SCI care, we think about sort of our team and who our team includes. And I always get asked by the residents, like, how long did it take you to develop your network? Because, I remember starting as a new attending and I don't think I knew as many specialists. And I had a great peer mentor, and it was like, I would go to him and I would say, hey, John, who do you rely on if you need to work with an orthopedist who is familiar with heterotopic ossification, right? It obviously it takes practice, and it just takes time and the accumulation of work to develop those networks. But when we're thinking about coordinated SCI care, we really are thinking about sort of a big umbrella of folks who come together to collaborate on some of the complicated issues we see. And so these can be specialties such as PM&R, of course, but also things like primary care, urology, and in primary care, I want to also include pediatrics for pediatric patients, also endocrinology for bone health, infectious disease, pulmonology, gastroenterology, psychiatry and psychology, potentially obstetrics and gynecology for our female patients, things like sports medicine, orthopedic surgery, and obviously neurosurgery, and then also other disciplines, including therapy disciplines, and then folks like nursing and nutrition. So, as I say, it takes a village. And then I think, again, last but not least, communication with community resources is really important. So they may not be part of the clinical team necessarily that is based in clinic or based in the hospital, but they are really important to think about to help achieve both patient well-being and promote independence. And these can look very different based on where you're practicing, if it's urban or if it's rural, and how folks will be going hopefully back home, but also sort of where home is. Is it distant from you? Is it rural? If you're at a tertiary academic center, but that collaboration being important for coordinated SCI care and for having the best outcomes for your panel patients wherever they may be coming from. Okay, so we'll talk a little bit about different examples of the components if we look at the chronic care model, but how these are embodied within SCI models of care. And hopefully you'll get the impression by the end of this presentation that in SCI care, I really think we have been doing a chronic care model of care since before it was cool, and since really before it even had a name. But we'll talk a little bit about the different components. So self-management support, there are some really wonderful resources. The Model Systems Knowledge Translation Center, the safe wheelchair training and wheelchair maintenance. These are actually online courses that you can take if you're a consumer, if you're a patient, or if you're just curious, if you're a provider and you're curious about this and you wanted to learn more. So our colleagues from really multiple different model systems, but spearheaded by the University of Pittsburgh, put together infographics and, like I said, several video courses to help look at safe, independent manual wheelchair transfers. So these would be self-management support resources in terms of education and how patients or consumers can receive more resources or education to help manage chronic conditions better. There's also peer resources through, for instance, like I said, United Spinal and the National Paralysis Resource Center through the Christopher and Dana Reeve Foundation also has peer mentoring resources, but these will also help with self-management. Clinical information systems. As I said, everyone does this a little bit differently based on their electronic medical record, but this is a really interesting paper from colleagues in Denmark and at Mount Sinai that looked at data collection and reporting for spinal cord injury. Dr. Bjørn Sorensen from Denmark is a real evangelist for the international spinal cord injury data sets and has had these actually built into the national Danish health system EMR. And so they're captured for spinal cord injury patients in Denmark. And then again, here in the US, at Mount Sinai, they've worked on developing specialized flow sheets for capturing the ASIA, the INSCI exam. And they were able to write this up. And then thinking from a research perspective, the National Spinal Cord Injury Model Systems database and how that information is captured and really curated, and how now with the new NIH guidelines, there is public access to de-identified data. And so I think we're sort of witnessing more democracy in terms of some of the data sets that are available and that are collected with federal grants. But this is important, I think, to consider, just because these systems do evolve over time as well. And I know there's a great interest in making these more responsive and easier for folks to use and for patients certainly to respond to and submit data. For instance, through REDCap surveys and through mobile apps and things like that. So I think that will continue to develop and evolve over time as clinical IT systems evolve as well. Delivery system redesign, I think, is important to think about, but these, I think, there's a lot of great examples of clinical tools that can be used by team members, depending on whether there's a nurse-led team, or there's a PM&R led team, or a primary care led team that involves PM&R. I'm not as familiar with pharmacist led teams in spinal cord injury, but I'm sure that that would actually be interesting to think about for our folks who are on maybe different medication cocktails, maybe sort of SCI plus diabetes, or refractory AD is one I think that might be interesting to consider having pharmacy involvement, although I'm not sure about pharmacist led. So these I wanted to share came out of a collaboration between the University of Ottawa and the Ontario Neurotrauma Foundation. But these are checklists in terms of thinking about how to provide sort of good primary care and check the boxes so that you don't leave some of these chronic conditions unaddressed while you're also addressing acute conditions. There are a lot of great international examples, I think, of delivery system redesign, which probably speaks to fewer barriers in some cases that I think US providers may encounter as just part of health system delivery in those countries. But the Queensland's spinal cord injury outreach team and the injury service are a great example. So the outreach team, or SPOT, is really a community-based team of spinal cord injury providers, including nursing medical occupational therapy, physical therapy, and social work professionals who also work with the inpatient services. And so you can see the delivery system really spans these sites of care from acute injury all the way out to the community. And they put out a lot of really wonderful resources as well. There's a phenomenal guide for parents with spinal cord injury that the SPOT team put out that is great if you are interested and you have a patient who has just had a baby and they're interested. There's a lot of wonderful tools there on sort of adaptive parenting hacks for spinal cord injury patients. And I'll go back to the VA directive. So this is essentially the manual for creating a spinal cord injury system of care, but sort of is memorialized in VA Directive 1176 here if you're interested. But this I think would be a maybe is overkill, but is quite inclusive in terms of thinking about all of the structural and process factors you would want to include if you were designing a spinal cord injury system from scratch. Decision support. So I think we have a lot of decision support tools in spinal cord injury. One might argue that some of them get confusing sometimes, but we have we do have the model systems data set. We also have the international spinal cord injury data set, which again is used and incorporated into some EMRs. And then we have facts and figures at a glance. So when we talk about decision support, we often think of provider feedback. And so this is also feedback in terms of how well are your patients doing compared to sort of the national facts and figures. For healthcare organization, again, we can think of different ways to organize and different goals that rehab facilities have. I think within the US, there's a lot of facilities that are governed by the organization of the IRF regulations and providing 3 hours of care 5 days a week and really providing that. And that is their goal. I don't think there's as much focus on, how do we make those services and that expertise accessible on a broad level? But I will tell you about some really interesting work, including by colleagues at Hopkins. There, are a couple of different examples, but it tends to be less common in the US. I think of, for instance, the WWAMI or in the Northwest federally funded program that really started telehealth in the 1970s, where specialists can pick up a phone and reach somebody. For instance, if you're out in rural Alaska, you could call a center in Seattle and they could connect you with somebody at University of Washington who knew about spinal cord injuries and making that expertise accessible in terms of how to organize that and how it's funded. Community resources. There's a lot of amazing community resources. I want to be mindful of time, but facing disability is great for spinal cord injury for patients. Christopher and Dana Reeve Foundation I've mentioned, and things that are again. Kenny Krieger did wonderful work to help put together the autonomic dysreflexia card here that is offered publicly and free of charge by the National Paralysis Resource Center. But these are things that, again, range from very concrete that are more clinically focused to, adaptive sports programming. And these are all part of, I think, really comprehensive SCI care and what we're able to provide. So why is SCI care unique? I think really, we have a social justice lens to looking at this. From the Convention on the Rights of Persons with Disabilities, we really approach it from a rights-based approach and sort of trying to get people back to the community. We also look at it long-term. So looking at the burden of spinal cord injury disease and trying to help promote health long-term, I think we excel in that, even more than some of our other colleagues looking at chronic care models. And this is just looking at the Lancet global burden of spinal cord injury among neurologic disorders. We also, I think, are really collaborative. So, in terms of trying to expand that expertise, we don't have a phone that we can pick up, but we do have a wonderful series. This was published in 2020 and 2021 in Topics in Spinal Cord Injury Research, but it's a wonderful compilation of resources that look at primary care providers and guides to different concerns within spinal cord injury, be they spasticity, AD, accessibility, or preventive health. So we focus long-term on community participation. We have meaningful performance and outcome metrics that capture health and function across settings. We provide context-specific care, and we use standardized tools and databases. So we're masters of sort of the context specific, but also looking at standardized tools so that, an ASIA exam in Denmark is the same ASIA exam that is here in Massachusetts is the same as it is in Maryland. We have clinical research approaches that are simultaneously systems-based and both consumer and patient-centered. And we collaborate across disciplines, institutions, and organizations. So like I said, we are providing this exemplary chronic care before it was formalized into the chronic care model. Opportunities and challenges I wanted to just mention quickly. I think transparency and reporting, it will be really important in healthcare currently and even more in the future. And so I think with this, it's important to think about what are our metrics that are publicly facing and how there are efforts to unify payment systems within post-acute care and what that means for complex spinal cord injury patients. I'm really interested in sort of all sorts of things, whether you like them or hate them, but Maryland I thought was interesting because they have this thing called Where the Cost, and sort of how we think of public reporting of costs and complications as well, I think is important to think about. That represents both an opportunity and a challenge. And then from health equity perspective, I think capturing more, we're great at capturing disability within the PM&R field, but capturing the intersectionality of how that relates to other demographic factors like race and ethnicity and gender, and then how that impacts us at both a national level and a state level. So I've included some things here from Massachusetts, but we do have disparities here in Massachusetts that we're looking at, and we also have disability healthcare costs in Massachusetts that are 37% of our state's healthcare spending. So in conclusion, high quality comprehensive SCI care incorporates structural process and outcome measures. SCI models share similarities with other complex healthcare models and are built on a social justice lens. And they have parallels, but they have unique long-term and community-based perspectives. There are numerous challenges and opportunities facing spinal cord injury providers and systems of care, including value-based care, care continuity across settings, and measuring health equity and value. These are my references, and thank you so much. I really appreciate everyone attending, and I'm happy to answer any questions. If you have something that we can't get to today, please feel free to email me.
All right. Well, again, Dr. Slocum, thank you so much for this really interesting presentation. I think this is a really great view of not only spinal cord injury, but just health equity and issues that face us by caring for disabled populations. And so thank you for kind of taking it in focus and sharing your experience. And everyone, I hope you have a great day.
Thank you so much, Dr. Friedlander.